Today we will discuss about atrial fibrillation. So before discussing atrial fibrillation, first we have to know what is the meaning of fibrillation first. See, normally suppose this is the muscle and the muscle contains several muscle fibers. So in order to contract a muscle, all the muscle fibers should work in a synchronization. So suppose a muscle gets pulled, so all the fibers should be pulled in a synchronized fashion. At the same time, this muscle fiber should work. Otherwise, what happens? Suppose this is the muscle and one fiber will be contracting less and one fiber will be expanding more and another less and another in another fashion. So this will cause a pattern called fibrillation. In a similar fashion, suppose there is a bucket of water, and when you tap this bucket full of water at one side, it creates ripples in an orderly fashion like this. For suppose there is another bucket of water, and if you tap at multiple places at the same time, you won't see any ripples. There will be irregular waves. So this is what happens in the atrial fibrillation. So if I can zoom here, see, this is the sinoatrial node where the impulse is generated. And normally what happens, the normal heart, when the sinoatrial node gets activated, it will send a number of waves in an equal fashion like this, and one wave will be going to AV node. So in the atrial fibrillation, what happens, even though there is a sinoatrial node, there will be multiple foci. So this will be generating electrical impulse, and this will be generating electrical impulse, this and this one. So together what happens is like there will be a asynchrony in the muscle contraction. So that's the reason. See, in the normal ECG you can see the P wave. P wave is actually the atrial contraction, and then followed by QRS and then T wave, and again the same. So in atrial fibrillation what happens, because of the asynchrony, you can see multiple small P waves and QRS, and this is called undulating P wave, or in some ECGs you can see an undulating or a flat P wave. You can see in this pattern followed by QRS, or you don't see any P wave. You simply see a QRS and followed by T wave. So in order to diagnose atrial fibrillation, there are two criteria. One is like there will be undulating and flat P wave, and second one is there will be irregular RR interval. So no P wave and irregular RR interval. If you see these two, that's enough to diagnose the atrial fibrillation. And you have to know about the atrial fibrillation and atrial flutter. See, the difference between atrial fibrillation and flutter is like, you can see there are no P wave and irregular RR intervals, and in atrial flutter what happens, you will see multiple P waves, so which will be a sawtooth pattern. Whenever you see this sawtooth pattern, that is called atrial flutter. So now let's discuss about the different types of AF. So one is new onset AF. New onset is like, this is the first time he is having AF. And number two is paroxysmal. What is paroxysmal? Patient will be having AF for sometimes, and then there will be no AF, and after some time again and again it comes and goes. And number three is persistent. What is persistent AF? Patient will be having continuous AF, and whenever you give the treatment, that will subside. And fourth one is permanent AF. Permanent AF is like, whatever you do, the AF will be permanent for rest of the life. And let's now we'll go to the causes of AF. Causes of AF will be, one is cardiogenic cause and non-cardiogenic cause. Cardiogenic causes are, there will be ischemic heart disease, heart failure, hypertension, or any valvular diseases. And sometimes patient will with pericarditis, they will also present with AF and cardiomyopathies. So these are some of the causes of cardiogenic. Now non-cardiogenic will be most commonly sepsis. In sepsis, pulmonary embolism, and then thyrotoxicosis, where the thyroid hormone will be more, and this will cause arrhythmias. And electrocution, patient after getting electric shock, high voltage electric shock, patient may have AF. And lung or pleural disease, and then hypokalemia or hypovolemic shock also, patient will be having AF. So let us discuss some pathophysiology part just for a minute. So what happens in AF is like, these are the atria and these are the ventricles, and here there will be opening of the pulmonary veins. So there will be multiple impulses here, and atria literally it will be vibrating. So because of this, what happens is like, there will be a turbulent flow of blood that predisposes to a clot formation. So most of the times, apart from sinoatrial node, there will be other foci generating electrical impulse in pulmonary veins. So what happens if you don't treat the AF? Patient will be landing up into clots inside the heart, and these clots will be traveling to brain, and it will cause ischemic stroke. So regarding the treatment part, so whenever you see an AF, first we have to see whether the patient is stable, whether the patient is stable or not. If the patient is stable, again you have to check for the rate if it is more than 200, and whether there is broad QRS complex. Rate of more than 200 and broad QRS complex. What you do, if the rate is more than 200, you have to do DC cardioversion, and patient is stable. Patient is stable and the rate is less than 200, like 180 for example. What you have to do is, like, there are two options here: AF occurring less than 48 hours and onset of AF more than 48 hours. I'll just mention here. Okay, 48 hours. If it is less than 48 hours, what you have to do, you have to control the rhythm control strategy you have to follow. And in rhythm control there will be electrical, which will be synchronized cardioversion 120 to 150 joules. And one more thing, pharmacological. So in the pharmacological part, again you have to see if there is any evidence of ischemic heart disease or LV dysfunction. So if there is LV dysfunction, if it is yes, then you have to give amiodarone. If there is no LV dysfunction, you have to give flecainide. So I will repeat it again. If the onset of AF is less than 48 hours, you have to do the rhythm control. So rhythm control, there will be two options. One is electrical and one is pharmacological. In electrical, you have to do synchronized cardioversion 120 to 150 joules after giving sedation. And in the pharmacological treatment, you have to again check whether the patient is having any signs of ischemic heart disease and LV dysfunction. If there is LV dysfunction, you have to give amiodarone, and if there is no LV dysfunction, you have to give flecainide. Now let's move on to onset. If it is more than 48 hours, if there is onset more than 48 hours, you have to do the rate control. For rate control, you have to use beta blocker or calcium channel blockers. So beta blocker like bisoprolol or metoprolol. For calcium channel blockers, verapamil and diltiazem. So our aim should be to maintain the heart rate less than 110 beats per minute. This is our aim in the atrial fibrillation. And one more thing, if the patient is a known case of heart failure, the patient is having heart failure and he presented with AF. If these two are present, you have to give digoxin. So as there is a risk of forming the clots inside the heart, and there is a risk of ischemic stroke because of small emboli, you have to give anticoagulants. In order to give anticoagulants for this patient, there is a scoring system called Chad-Vas score. You can refer it in Google. So in Chad-Vas scoring system, Basically this tells us the uh, risk of how much risk the patient is having stroke. So you have done the scoring. If the score is 1, you have to consider giving anticoagulants. If the score is 2 or more than 2, so definitely you have to give the anticoagulants like apixaban, rivaroxaban, right? And there is one more scoring called orbit score. See, basically this orbit score will tells us the risk of major bleeding in patients with AF. So you have to assess the risk of major bleeding in these patients as you are giving the anticoagulants. So suppose there is a score of 0 to 2, it is a low score, and if it is a score of 4 or more than 4, it is a high risk. So patient will be having high risk of bleeding. So please refer to the you can have it in Google Chartware score and orbit score. You will have multiple images. So please refer to these scoring systems.